So, so as not to force our last speaker to introduce himself, as you may know, Dr. Schulman really has masterminded this entire conference, and so and we will thank him at the end. But now he's going to talk to us about an area that's of great importance. Let me introduce him and tell you about his qualifications. Brian Schulman is the Assistant Director of the MGH Center for Psychodynamic Training. He's an instructor in psychiatry at Harvard Medical School. He trained in adult psychiatry at the MGH McLean Residency Training Program, and where he did serve as the MGH Psychotherapy Chief Resident, much to my great pleasure, because I had the pleasure of working with him in that capacity. He was the recipient of the Ann Alonzo Psychotherapy Award when he graduated from the residency program. He received additional psychotherapy training in the Advanced Training Program in Psychoanalytic Psychotherapy. This was at the Boston Psychoanalytic Society and Institute. He's currently a faculty member both for the residency's program in psychodynamics, where he serves as a psychotherapy supervisor, and he's an educator both for residents and for our medical students at Mass General. He's also a board member of the Mass General Endowment for the Advancement of Psychotherapy, which sponsors this conference. He moderates a regular interdisciplinary case conference where therapists of all different orientations come together to talk about the same case. This is entitled Crosstalk. And Dr. Schulman has made one of his several areas of expertise to be how we understand combining medication with psychotherapy, something that's commonly done but not very much thought about in terms of the meanings of medication. And so it's an area that I think needs a lot more attention, and Dr. Schulman is a very thoughtful person to be turning his attention to this area. So he's going to talk to us now about understanding the medication experience. Dr. Schulman.
Thank you. So no disclosures. So I referenced earlier that I would talk about the medication piece as well. And just to be clear, I don't take the point of view that psychotherapy is preferred over medication. But to frame what I'm going to be talking about today, there's a pretty widespread issue of medication non-adherence, meaning patients not taking medications as prescribed. And this can be true for both psychiatric conditions as well as general health conditions. And in these studies, non-adherence was defined as not taking medications 80% of the time. So taking it fewer than 80% of the time was considered non-adherence. And we know that non-adherence can limit the effectiveness of a given treatment plan and lead to significant health consequences from undertreated conditions or symptoms, particularly where the treatment has very good medical support and where the consequences of undertreatment or non-treatment can be pretty severe. Oh, and just to make one more point about this, so I was talking about this topic with a colleague of mine, and she said, "Oh, that reminds me, I forgot to take my medication today." So it's certainly, none of us are exempt from this. So while we know there can be many possible causes of non-adherence, from lack of understanding to economic limitations, one set of factors is certainly psychological. And most people may be familiar with the placebo effect, but I'll delineate it, explain it a little bit more. So that's a therapeutic benefit of a given treatment that's associated with factors beyond the stated biological mechanism of action. So thought to be related to non-specific or contextual factors, such as aspects of therapeutic alliance. And we know that in studies of antidepressants, for example, up to 75% of the therapeutic benefit of antidepressants may come from this quote-unquote placebo effect. And we know that because the people in the placebo groups of these studies improve almost as much as the medication groups. Most people may be unfamiliar that there's actually another concept called the nocebo effect, and this is sort of the opposite concept, that you can actually experience adverse events or side effects associated with negative expectations, attitudes, or fears about treatment. And one way this has been studied is patients that were receiving an infusion of a painkiller, those that were told that the infusion had ended immediately reported an increase in their perception of pain compared to a group who also had the infusion stopped but weren't alerted at the exact time that it was stopped. So the expectation of a worsening can lead to an actual physical perception of worsening or discomfort. And of course, real factors are at play as well. So if someone has a rapid or really robust response to a medication, they're tolerating it well, they're going to have increased positive attitudes towards the treatment, towards potentially the provider that prescribed that treatment. Whereas if they're having trouble tolerating the treatment, if they're having a lot of side effects, they're not necessarily getting much benefit, they're going to have more negative attitudes, not just towards that treatment, but towards that maybe whole treatment plan and provider as well. And in the case of psychoactive medications, it's even more complicated because we have medications that have the possibility of directly impacting one's feelings and experience, and potentially reducing anxiety, potentially inducing some sort of euphoria, can immediately leave someone feeling changed or different, maybe even more so than is the case with physical medications. And as a result, it can evoke really strong feelings or associations. So what are some examples of positive feelings or associations that people may develop to medications? So they may feel a tremendous amount of hope that finally there's something that can help me. It may provide a direct validation of their suffering. Here, I really do need some medication to help me feel better. This is a sign that it wasn't all in my head, that it wasn't something that I am falsely believing is wrong with me. This really makes it clear that I do have a medical illness that needs prescribed treatment. And that can actually reduce stigma, can reduce self-blame, and they can also feel quite nurtured by the provider who's offering this treatment. This is a sign that this person really sees how much I'm suffering and understands that I need more help, can offer a sense of protection or strength. And while these generally are quite positive, occasionally they can go too far, that someone decides to increase on their own the doses of the medications they're taking because they feel so strongly about how much it's helping, and may or may not be sharing that with the prescriber, or they may be taking medication secretively or from non-prescribed sources, developing other sorts of addictive issues with particular medications. And what about negative feelings or concerns that people may have about medications, just in terms of basic beliefs? So it's a pretty common experience that people may prefer something that's quote unquote natural. The notion that medications are these chemicals, they can feel artificial or foreign, can have the sense that, I'm not really meant to take this on a regular basis. I'd much rather take something like a vitamin or a supplement, can feel more natural or health-inducing. And a lot of us have an impulse for self-efficacy. I should be able to do this on my own. The sense that a medication can feel like a crutch or an incredible concern about becoming dependent on a substance, even if it's not technically generally addictive. I'm going to try to hold the questions till the end, even if it's not generally an addictive substance. So those were a couple examples. It also can feel like an intrusion. It can feel like an avoidance of talking about deeper issues if the conversation gets steered towards discussion of medication and it feels like it's shortchanging a deepening of other topics. And taking medications themselves, whether for a physical health condition or mental health condition, can be uncomfortable because it can serve to remind you that you're sick, that you need a medication, that it can activate attitudes, expectations, wishes, and fears about having a diagnosis, about particular symptoms that can be uncomfortable, and thus someone may choose not to engage with the medication so as to not think about feeling sick. And then we've talked about change a lot. Well, often people feel some sort of mixed feelings about change, even when they're entering treatment. So it's quite common and normal when one's seeking treatment to have mixed feelings, that you want to feel better and have relief, but you also want to feel taken care of, to be accepted for who you are, and to not feel pressured to change too much or too quickly. And sometimes if a treatment is offered too early, or it can feel like a lack of validation of who you are and what it takes to come into this treatment. So those are, different examples of feelings, of expectations that people may have about medications, many of which may be not conscious to the person. They may not have a direct awareness of having those different feelings about medications. And those preconceived perceptions then interact with the actual behavior of the clinician. We've talked a lot about the nature of fit in therapy. I think it can also happen in a medication treatment as well, that a patient feels very pressured to do one thing or another, or finds an alliance with a provider who they feel really understands both their preferences and concerns, and the partnership there is really what allows for the best possible outcome. So these early positive attitudes can contribute to an improved therapeutic alliance, can lead to improved outcomes. We've heard examples of patients on the panel, can lead to feelings of competence, feeling that they can trust the provider, feeling cared for. But on the flip side, early negative attitudes can diminish trust, can diminish adherence, can diminish the effectiveness of treatment. There may be feelings of resentment, anger, hostility towards the provider or towards the treatment in general, feeling like they're not being understood. And so how do you address these topics in a combined treatment? And just to clarify, when I refer to combined treatment, I'm not exclusively referring to a single provider doing both the therapy and medication. There's also forms of split treatment where you may have a separate therapist and a separate prescriber. But I think having a space where in the med management piece, there's actually a discussion and allowance for exploration of these different concerns and feelings, really empowering the patient to feel like they can talk about those feelings, those concerns that, again, typically may not come up in a typical encounter with a physician, feeling comfortable enough to express their reservations, to express their preferences for treatment. And by having space, attending to that experience, how it really feels to take medication, both good and bad, and if someone's experiencing side effects, to work with them on what they're willing to tolerate and what their overall preferences are. And often, particularly in the psychiatric realm of medication options, there are multiple medications within a given drug class. So the first trial doesn't have to be the final one, and acknowledging that we're going to work together in some sort of a partnership to try to optimize your treatment. So I'm going to conclude with a brief case. And this actually interaction took place in my very first encounter with a patient. So I call it despite best clinical intentions. So I met this gentleman for the first time. He was referred to me by a colleague who was retiring, and so she had a few final sessions of overlap with me in the referral process. And in the process of meeting him, I took a history, as we've all discussed the importance of, and in reviewing his medications, I noticed that 2 of his medications that he used on just an as-needed basis seemed to be quite dangerous if taken in combination. And I alerted him to this concern that I had, and wanted to ensure that he was aware, knowing that often different medical providers may only focus on the treatment that they're prescribing and not necessarily be fully aware of the other medications that a patient's taking and potential interactions. And I thought I was being particularly diligent to alert him to this. But rather than appreciate this warning, he felt particularly demeaned, belittled, felt that I had really questioned his intelligence or knowledge, wanted to stop treatment with me right off the bat. And part of how I learned this was in ongoing communication with the referring provider, who, as I said, had some overlap in final sessions with me. And I was able to actually directly address this with him and go back to this point in time and really try to understand what had happened there, how he had experienced it. And it really not only opened up a bigger discussion, it really allowed the treatment to proceed. So I talk about role of prior experiences here, and this is sort of a connection to the notions of transference and patterns of prior relationships that has been mentioned in other talks today. And this was a man who was really a quite self-made, self-reliant man. He had risen from really meager economic circumstances to a position of pretty significant professional success through determination, hard work, and really was quite sensitive to the notion of his self-reliance being misconstrued. And when I was able to explain my intentions, and that I've often had the experience of not all providers being fully aware of all of the medications that a patient is taking, and I really, was not meaning to imply that he wasn't aware of this issue himself. And in fact, he was very knowledgeable and had known not to combine them. But being able to address that and address, his strong reaction to my even making that gesture, again, allowed for increased trust, and it's something that we've been able to come back to in the treatment at various points over time as something that he really appreciated, that I could address it directly, and that could attempt to rebuild that trust that could have been lost from the very beginning. So in conclusion, how do we apply these concepts, this notion of psychological factors contributing to medication treatments? So as a provider, even if I'm seeing someone in the frame of a medication management treatment, I really want to take a detailed history. I want to understand the patient's background and experiences. I think you heard that some of my patients say I don't jump to a diagnosis. I'm really trying to understand the person more than the diagnosis, trying to go beyond a checklist approach. And I really ask patients how they feel about taking medication, particularly people that have already come to be on medication. What's that like for you? Some people have had very different experiences, and they feel really committed to staying on a particular medication and feel like it's really made a huge difference in their treatment, and I acknowledge that as well, and also acknowledge when someone has a particularly strong reaction or feeling about, oh, I absolutely don't want to go on that medication, I associate that with X, or I had a family member who took that and I don't want to think of myself as in relation to that. And sometimes we can still work through those and actually even have the person end up taking that medication if it makes the most sense for them, but allowing space for this dialogue. I like to talk about the notion of a medication trial, because often if someone has not been on any prescriptions in the past, the notion of taking a medication can feel really scary. Like, does this mean I have to take this for the rest of my life? And as I say, there are certainly conditions that are would benefit from ongoing medication treatment. But if you use a fear tactic that this is something that you need to take the rest of your life, you may inevitably lead the patient to not want to disclose that they've stopped taking it. And you're sort of having this misinformed conversation together about what's actually going on. And it's important to attend not just to what is prescribed, but how. And the notion that this is a relationship, this is a dialogue, that addressing that, continuing to have this conversation, again, even if it's technically under the frame of a purely medication management treatment, I think can optimize outcomes overall.